almost 40 people, and it's a little after 7, so I think we can get started. So hello, everyone, and welcome to our 5th meeting of the year. We were just talking about it. We had a really excellent RFS meeting in January, and I want to just say congratulations to Shams Iqbal, who led that effort, and to the entire team who worked really hard on it, all the residents and multiple institutions. It was a record-breaking event in terms of attendance, and that is now available on nesser.org for anybody who missed it. And then before I introduce Dr. Sista, I just want to say stay tuned after his talk for case presentations. I know we have Dr. Han from BMC and Dr. Zhang from Brigham who are presenting, and also Trevor Lewis will be presenting. And I know some of these talks are pertinent, or excuse me, cases are pertinent to the talk, so I'm looking forward to them. In terms of Dr. Sista, we're honored to have him join us tonight, and I'm very excited to hear him speak. He's an associate professor of radiology at New York University, and he is the section chief of vascular and interventional radiology there. Dr. Sista attended medical school at Johns Hopkins and completed his residency in diagnostic radiology at UCSF and his fellowship in VIR at Stanford. Dr. Sista is an expert in venous thromboembolism, and he's a very accomplished researcher who's advanced in the field of interventional radiology. He's given more than 80 invited talks and has authored or co-authored over 50 papers. He's the principal investigator of the Evaluating the Safety and Efficacy of the Indigo Aspiration System in Acute Pulmonary Embolism, Extract PE trial. He's also on the steering committee of the C-TRACK trial and was a principal site investigator for the Attract trial and the Perfect and Respect registries. And additionally, he has grant funding from the RSNA to investigate the physiological consequences of submassive PE. And so, you know, I just realized in talking about that, I talked about a lot of devices. I just want to thank our sponsors tonight also, who've been very generous before we get started. So thank you to our sponsors. Thank you, Dr. Sista, for joining us. And without further ado, here's Dr. Sista.
Let's go to the beginning. How about that? Okay. Well, Ezra, thank you for the very kind introduction. It is truly a pleasure to speak to the New England Society of Interventional Radiology. It's a timely topic, I think, and it's something that's on a lot of people's minds. We're seeing a lot of posts on Twitter and social media about big clots, and you know, the question is, are we doing the right thing? And I think this is a very good time to step back and try to answer that question and see what we need to do to really figure out what we should be doing for our patients with severe PE. So I have basic, you know, when I used to give a talk like this back, you know, 5-6 years ago, I used to go really into the fundamentals of definitions, et cetera. But I think we've all advanced so far that I'm going to assume quite a bit of knowledge in terms of PE stratification and just dive into sort of the more maybe stimulating topics on mostly submassive PE. I'll talk a little bit about massive PE, but really I think the focus of this talk is going to be on the equipoise and uncertainty following surrounding submassive PE and endovascular therapy for it. So this is the title. You see this big clot on the screen. This is actually taken from a surgical embolectomy, but I think we've each seen some pretty big clot removed percutaneously, and that's an exciting point for us to get to, that we can start rivaling open surgical embolectomy. That was definitely not true a few years ago. So the devices are technologically getting there. Now we just need to see if it's the right thing to do and in which patients. So these disclosures are relevant. I did receive a research grant from Penumbra when we conducting the Extract PE trial as the national principal investigator. I'm currently on the Thrombolex advisory board. I am unpaid in this position, but I am getting a research grant that's given to my institution to run their pivotal trial, the Rescue PE trial, which is underway. I'm on the advisory board for Vascular Medicure, and this is also a first-in-man clinical trial that's coming up. That's a thrombus extraction device for PE. I received a research grant from Argonne Medical for venous thromboembolism studies. I currently am in a no-cost extension for a U34 planning grant I was awarded by the NIH, the NIHLBI, the same institute that sponsored the ATTRACT and CTRACT trials. And you saw, you heard from Ezra that I'm a part of the CTRACT trial as well. So, I would say that from an endovascular device perspective, there has been a rapid acceleration in the last 5 to 6 years. So I think it all started in 2014 when PITHO was published and showed its very, very interesting findings. That spurred a bunch of systemic lytic meta-analyses. And then Ultima came out around the same time showing a very, very good bleeding profile, and at the same time showing efficacy for the first time really for catheter-directed thrombolysis. 2015 saw the publication of Seattle 2, which is really the basis of all of the subsequent pivotal trials that are getting FDA clearance for new devices. Will Kuo published his Perfect Registry that year as well. Then in 2017, this I like to call the year that we started thinking about the long-term a little bit more for PE, and the long-term results from the PITHO trial came out. ELOPE, the Susan Kahn study, which was an observational study in Canada looking at the long-term consequences of PE, was published in Chest. In 2018, the Optilice trial was published, as well as the FLAIR trial, which was the pivotal study for the FlowTriever device for PE. In 2019, we completed the Extract PE trial, which was the Indigo aspiration system. And then beyond 2019, we have hopefully this consortium registry, which will give us massive data on all of the PE activations that happen around the country. Vascular Medcure, which I talked about just in the previous slide. The Rescue PE study is going on currently. Right now, its enrollment is about 30 patients. And then I'll tell you a little bit more about our efforts with PE Tract. So I'm not going to spend a ton of time on massive PE, but I think it's important just for us to remember that this is a very different disease than submassive PE. And I think I'm really doing this to highlight that difference. So the first point I'd like to make is that systemic thrombolysis is definitely underused. At least it might be picking up currently for massive PE, but this is a publication by Paul Stein, and it's got its limitations. It's taken from the National Inpatient Database, but it kind of showed that patients who received thrombolytic therapy and had hypotension with their PE had less all-cause fatality than those who did not receive it. Now, there's a lot of reasons why this might be the case, but it is a striking statistic, a signal, so to speak, that we should take a look at. And the funny thing is that in spite of data like this and other data, you see that there's a decline in the number of patients who received thrombolytic therapy up till 2008. I would like this updated. I'm not sure if it's out there, but that would imply that the fear is not matching the data. That being said, there are some patients in whom thrombolytics are contraindicated and in whom they fail. And there are these other options, catheter-directed therapy and surgical embolectomy. When we're talking about catheter therapies for massive PE, you see all of them here basically. And actually, this is just a sampling of all the devices that could be used. And I liken it to the kitchen sink in the sense that when you have a patient who's hypotensive and crashing on your table, you just do whatever you need to get them to get perfusion from their right heart to their left heart. Just bore a hole in it, get perfusion to the left side so you can start perfusing the coronary arteries, which will help that right ventricle kick in. And then hopefully you have some savvy anesthesiologists who are administering epinephrine and whipping that right ventricle, because as soon as that right ventricle stops beating with an obstruction in the pulmonary arteries, that's when that cycle, that spiral of death that we've all seen in both the literature and hopefully not too often in our practices. But this is the point being that you do whatever you can to improve perfusion. I'll highlight one case we did last year. This is a classic massive PE situation that required something that systemic thrombolysis just couldn't solve. So a 54-year-old man, he had a previous resection of a glioma, complex closure. He was scheduled for a repeat closure, but then of course he had a pre-op DVT, very common in people with GBMs, and he had an IVC filter placed because he couldn't get anticoagulated. In spite of the IVC filter, he had hypotension and hypoxia and had a PE. The PERT was called once and he was okay initially, but then he became more tachycardic and hypotensive. CT showed a large embolus in the right main pulmonary artery and in the left lower lobe pulmonary artery. And really for this case, there's no option for systemic thrombolytics. He would probably have a massive bleed into his brain. So we went in from the groin, used the FlowTriever device, and you can see on this panel, this sort of obtuse thrombus that corresponded to what we saw on the CT scan. And then when the thrombus is removed, you see that more acute angle right there. There's some residual thrombus, but his hemodynamics picked up very quickly as soon as that thrombus was removed. On the left side, I'm not going to claim much success here. Really no difference between the pre and post. I think we still got some clot out, but the angiogram was not terribly impressive. So we saw an immediate result on the table. Before we did this, his pulmonary artery pressure was elevated. After the thrombectomy, you see it took a pretty big dive downward, and this was with his right ventricle working well. So it wasn't like this pressure was as a result of his right ventricle failing. His oxygen saturation went up 5%, and he was weaned off pressors. He was extubated that evening. So a good result, at least on the table. Of course, he had a terrible disease, but at least in that moment, the procedure worked well. So, you know, it's hard with massive PE to talk about anything more than individual cases, but that's still not going to move the needle really for patients from a large data perspective. So, I mean, one question is, can we improve the data by doing a randomized controlled trial with massive PE? And if you look at a back of the envelope calculation, it just doesn't seem feasible. So let's crunch the numbers. So if you have a 800-bed hospital, that hospital probably has about 200 PEs per year. Just assuming that the epidemiology in that hospital is the same as the country, 5% of those PEs are going to be massive. So you get 10 massive PEs per year from that hospital. Let's assume you're able to enroll 40% of those patients, that they are willing to be randomized into this RCT that you've designed. You'll be able to put in to enroll 4 massive PEs per year at your institution. And then what the question is, what are you going to randomize them to? Are you going to have a 3-arm study? And what is your expected effect size between these? You know, you can't just anticoagulate a massive PE. That's not going to work. So trying to figure out which one of these therapies and which one's going to be better, it's just not possible. And you can't power a study if you don't know the effect size. And most likely, the effect size between these is not going to be large enough for you to have a small trial. So you're really looking at a very, very difficult RCT to conduct. So my thought is that we really need a massive PE registry. Perhaps the PERT consortium would be the appropriate body to help with this, but really trying to enroll these patients as soon as they hit the door rather than after they get a therapy. And, you know, if they're able to be enrolled immediately, we will get really true registry data rather than picking the ones that actually live and following those, which is typically what happens in registry. Now that's difficult, but if we can get to the point that we just enroll these patients somehow, we get detailed baseline characteristics, make sure every patient is included regardless of the outcome, and details on the intervention. And then we follow those patients for 7 and 30 days and for a year, and hopefully we get some indications or some hints as to what is working, what's not working, and we can improve care for these patients. But I think that's the best we can do for massive PE. So moving on to submassive PE, well, this is a totally different disease if you ask me, even though the pathophysiology is the same. If you look at the mortality of submassive PE from Pytho, it's less than 2% and a 5% rate of clinical deterioration. That you can contrast that with the 25 to 65% mortality that you get with massive PE. So it's very clear with massive PE, you're trying to rescue that patient from death. But what are we really trying to do with submassive PE? Are we trying to prevent death and clinical deterioration in that small subpopulation of submassive PE that is headed the wrong way? Are we trying to reduce long-term disability in these patients? I'll say a lot more about that in some coming slides. But really, this is the problem. We don't really know why we intervene on submassive PE at this point. So where did this idea come from that we should potentially be more aggressive with submassive PE? So the ICOPA registry was with Sam Goldhaber as the first author of this study. It was a global registry of about 2,800 patients. And really it was observational in design and in its results. And one interesting one was that 90-day mortality was more common in patients who had right ventricular hypokinesis. And you can see that the curve separated out very early. So perhaps these patients that had right ventricular hypokinesis needed more than just anticoagulation. So, that led to the MAPIT trial in the early 2000s conducted by Stavros Konstantinides. There was about 250 patients. That trial showed a potential benefit, but it was due to rescue thrombolysis being used more commonly in the placebo group than in the intervention group. So they designed a much larger trial. They used tenecteplase this time instead of alteplase because they could administer it as a bolus, and they could very easily have a placebo arm. And this was its main outcome. From an efficacy standpoint, it actually met it was actually a positive trial. You can see that tenecteplase actually had its primary outcome happen less commonly with a p-value less than 0.05 than the placebo group. But if you dive into that number, you see that most of this was a result of more hemodynamic decompensation in the placebo group, and that mortality was really no different. It was less than 2% in both groups, whereas it was 5%, a 5% rate of hemodynamic deterioration in the placebo group. The problem is this was tempered by the fact that there was just so much more bleeding in the tenecteplase group, 11.5% major bleeding rate, and then the dreaded intracranial hemorrhage happened in 2% of patients, which sort of parallels what we've seen in other studies of systemic thrombolysis. So really a lot of people at that point said, well, systemic thrombolysis is maybe not the best thing to do for most patients with submassive PE because that therapeutic profile is really not favorable enough to do this routinely. So in steps in catheter-directed therapy, can this therapy get all the benefits of intravenous thrombolysis and really minimize the risks? And theoretically, that's true. By embedding this catheter in thrombus, we're hoping that the clot acts as a sump for the fibrinolytic drug, and therefore you don't need as much drug, and that drug doesn't go systemically as much compared to a intravenous thrombolysis, which is administered peripherally. When we're talking about catheter therapies with the fibrinolytic drug, there are really three types of catheters we have right now. The first is just a standard infusion catheter, which we're all familiar with. This is the ECOS catheter, which is really what CDT has been studied with the most. You have to tip your hat to the company for providing that data. That certainly got us off the ground. And then this is the Thrombolex catheter, the shear endovascular catheter. Now, this theoretically has a sort of maceration component. When this expands into this basket, it's thought to fissure the clot and then administers fibrinolytic drug through these 6 limbs and in a different place than the sort of central administration through a central lumen. This is thought to give a more, it allows the drug to be administered throughout the clot rather than just in one plane with these standard infusion catheters. So this is the one that's being trialed right now in the Rescue PE trial. So if we look at the data, this is what we have so far as prospective CDT trials. Of these, this is the only one that was actually randomized. People say that the Optimize trial was a randomized trial, but it really didn't include a control arm. So I don't think that's the traditional definition of randomization that we're looking at. Seattle 2 single arm, perfect single arm. The Sunset trial is randomized, but it's not randomized to anticoagulation versus CDT. It was randomized to turning the ECOS ultrasound apparatus on or off and looking at the results of that. I'm not going to really talk about the Sunset trial because it's only been presented in a meeting and it's not been published yet, but I do think it's an interesting trial that is something to talk about when it does come out. And then the rescue trial is ongoing. I think this is a really important slide. And the reason is that this is the only slide that we can point to that says CDT does more than anticoagulation. So at 24 hours in the Ultima trial, they used echocardiography and they showed that their CDT protocol more rapidly reduced the RV to LV ratio than anticoagulation alone. And this is the only evidence we have to this point that it does more than anticoagulation. The rest of the trials are single arm and they look at 48 hours and the CT findings. Now, just so everybody is aware, 48 hours is 48 hours from the procedure. It doesn't mean it's 48 hours from the first CT. So if you can imagine the scenario where a patient comes in on a Saturday night, gets the CT scan, the next day gets enrolled into the study, and then maybe gets treated at 3 p.m. in the afternoon. The next day gets the catheters removed, and then gets the 48-hour CT at on a Tuesday. So it's already been 3 days from the initial CT scan, and that's what the measurement is. So even though the CT is at 48 hours, there's been a lot more time than that heparin and autolysis have been given the opportunity to work. So attributing this difference to CDT is problematic because you don't have a control group. And to this day, we still don't know what the 48-hour CT looks like in patients who receive anticoagulation alone. I just think that's an interesting and important point. Well, what about so we just talked about efficacy. What about the bleeding side? Well, this is the Seattle 2 data. Now you can see here that major bleeding did happen in this trial at a clip of 11%. Now, some of these bleeds were access site bleeds, and really it was a pretty strict definition of bleeding in that if you had a 2-gram hemoglobin drop, that was considered a major bleed, and that was most of the bleeds. But there were some cases of hemoptysis. There were retroperitoneal bleeds. It wasn't only access site bleeding and minor bleeding, and there was one severe bleed. The important finding was that there were no intracranial hemorrhages. This was a good thing. However, you go to the Optimize trial, and there were some intracranial bleeds. Sorry about that. There were 2 intracranial bleeds. One of the intracranial bleeds did happen in a patient who received systemic thrombolytic therapy, and so that was a bit of a protocol violation. But the other one did happen per protocol, and it was in the highest dose arm. For those of you familiar with Optimize, it's a complex study. I'm not going to go into the mechanics of it, but there was intracranial bleeding in the study, and true to form. If you look at all of the studies in this meta-analysis, there are intracranial hemorrhages that are reported in the literature. We estimate that intracranial hemorrhage happens with CDT in about 0.3 to 0.4% of patients, and that the major bleeding rate is around 5% if you look across these studies. So all of this bleeding makes people think, well, why are we trying to remove thrombus with fibrinolytic drugs? Couldn't we just try to extract the drug, the clot, and achieve the same result and not put the patient at risk for bleeding? And these are the technologies that do this. This is the AngioVac device. It has fallen out of favor for PE, but there's a next generation out there that the company is working on that may change that perception, and hopefully it does. We do want these companies to keep innovating and getting better and giving us better tools, and I fully encourage that. This is the JEDI for people who are not familiar with it. It has this sort of water piston that breaks up thrombus as the clot enters the mouth of the catheter. This is that vascular med cure catheter. which has sort of a windsock and pulls it. It's a little bit akin to the ClotTriever for those who are familiar with the ClotTriever, except it's got a different mechanism for opening up this windsock, and then it pulls it into this catheter. This is the Indigo system. It now goes up to 12 French, FDA cleared for PE. The cleaner is not FDA cleared for PE, nor are these yet. I have used it in massive PE as a automated sort of pigtail spin. I did my first massive PE case. I tried to spin a pigtail and I was getting nowhere. So I just turned to this device, which I'd looked at before and thought about for massive PE, and it kind of worked. It can rotate at 3,000 RPM. And it has a pretty soft tip. One thing to worry about in the pulmonary artery is that it doesn't really have an adventitia, so you can puncture the pulmonary artery pretty easily. And then this is the FlowTriever device, which all of us are familiar with, which is also FDA cleared for PE. And these are the trials that enabled FDA clearance. The FLAIR trial is what gained clearance for the FlowTriever device, and the Extract PE trial was what allowed the Indigo system to be cleared for PE work. So what about efficacy for these new devices? So if you look across the board, if you look at the change in the RV to LV ratio at 48 hours, pretty much preserved across these trials. So Seattle 2, you had a 0.4 unit reduction. Extract PE a 0.4 unit reduction, and FLAIR a 0.4 unit reduction. So, if they all work the same, maybe they all, it's hard to really hang your hat on this, because again, none of these trials had a control group. So we don't know how much autolysis and anticoagulation are doing to reduce that RV to LV ratio. That being said, it's a good signal, it's a good direction. We just need better and stronger data. So here's where I'm going to start talking about this problem that we have in endovascular therapy for PE right now. So since Ultima, interventional trials have not included a control group. So if you look down the list, it started with Seattle 2, Optolice, FLAIR, Extract PE, Rescue PE doesn't have it. Catheter will not have it. This is the vascular Medcare, the windsock device. None of these is going to have a control group. There's no motivation to include a control group when you're trying to get your device cleared. So, this is, so they're talking about the RV to LV ratio, but what about these other endpoints like death, deterioration, long-term dyspnea, quality of life, and how do these devices compare to just really good anticoagulation and close monitoring, advanced supportive care, like we've really done a much better job of now? I'll tell you, we don't do a ton of CDT outside of the trials at NYU, and we follow our outcomes, and there are not a lot of submassive PE patients who are dying from not getting intervened on or reperfused in some way. So much for the timing of that question mark. Okay, so moving to data gaps around catheter therapies. So we've sort of talked about one, which is the lack of clinical outcome research that has plagued us. So we don't know about short-term mortality and clinical deterioration in terms of endovascular therapy compared to anticoagulation alone. We don't know how it affects long-term exercise tolerance, quality of life, the incidence of chronic thromboembolic pulmonary hypertension and chronic thromboembolic disease. We don't know enough about the safety of these devices yet. We have small trials. We need a lot more patients enrolled in whatever to figure out what exactly the safety profile is of each of these devices. There are a bunch of technical questions too. I mean, what is the best method of clot removal? Should we be using a lytic? And when should we be using lytic, and when should we not be using lytic? Perhaps it's okay to remove some proximal thrombus with some of these devices, but is it beneficial in the long term to have a thrombolytic drug perfuse the entire lung? And is that going to result in a better long-term outcome than, say, just removing some proximal thrombus? We don't know the answer to these questions. We also don't know when we're using these devices, these thrombectomy devices, when we should stop. And when we say we should stop, what is the outcome we're looking for? Are we looking to just get the patient off the table and get them into a more stable situation, or are we really looking out for their long-term outcome? And should we be going after as much clot as possible? This idea of enhanced thrombolytic catheters, both the Bashir endovascular catheter and the ECOS catheter, they're significantly more expensive than standard lytic catheters. They come with a lot more hardware and a bigger footprint. And so should the healthcare system be spending that money on these catheters? Are they truly better than a standard catheter? We need to figure out the answer to that question. And then from a basic science standpoint, do these devices do anything to thrombogenesis? I mean, when we place these devices up there, are we actually inducing thrombogenesis? Do we have to make these people really anticoagulated? And does that change the safety profile of these devices? And are we damaging the endothelium in the near term, and does that have a consequence in the long term? The list goes on and on when you're talking about some of the mechanistic issues that come up from catheter-directed therapy. So, these catheter devices for PE, there's tremendous innovation going on in the space. So you look across the board, and I've been so impressed with what these companies have come forth with. And it's great to see that much intelligence and innovation directed towards venous thromboembolism. Here's the problem, right now we're doing about 20,000 procedures per year, and we don't know if we should be doing all of those. And in some of these industry filings, they think the total market cap for procedures is 200,000. To put that into perspective, there are about at most 600,000 PEs per year in the US. And so they're talking about doing an endovascular thrombus extraction for a third of those, which is really something we need to start thinking about, and maybe wrest it from aggressive industry partners and figure out which patients we should be doing this in. And as grateful as I am, and as we should be to these industry-sponsored trials because they got the ball rolling, they're really not motivated to answer the most fundamental PE questions. Industry-sponsored trials we've seen don't have the same methodological rigor as an NIH trial. There are concerns for bias. They don't have the same degree of credibility to our other stakeholders, such as the pulmonologists and the hematologists, the ones that really are looking at us at scans and saying, why do you want to remove thrombus from this patient? They are conducted to enhance market share to some degree. They can't just be in a vacuum and be pure scientists. That's just, they're in business, and they have to acknowledge that. This is not a knock on industry. This is the market. But the problem with that is that their motives don't always align with a patient-centered and clinically meaningful health outcome. Meaning, are they going to put their device at risk by putting it up against anticoagulation for outcomes that are not clearly shown to be of benefit when we do endovascular therapy? So really, we need to think about these limitations and see how we can get to a better place of understanding. Because right now, this is from Dante's whatever circle of hell, which is limbo. You hear he has Aristotle and Socrates all debating about different things. And this is kind of where we are with our PERT teams. So we're all looking around at each other saying, well, should we do this? I don't know. Should we do this? Maybe. And that's really a function of a lack of data. And, we published this back in 2017, but this is sort of the roller coaster we were on. We were, in late 2013, we were doing a ton of CDT cases. I think in January of 2014, we did something like 14. Can you believe that? Or I'm sorry, this is the number of activations, and this is the number of CDT cases. So you can see that between December and January, we did something like 6 or 7 CDT cases. And then all of a sudden it plummeted. And I think the reason for this was we actually had a complication. And so, you can't, there's a saying, you shouldn't be basing your practice on the last case you did. You want a large number of patients that have been studied so that even if you do have a complication, you have confidence that you're doing the right thing when the next patient comes around. And then, of course, you have the difference between interventionalists and non-interventionalists when it comes to their perception of CDT. And these were just different clinical scenarios asking physicians, would you employ CDT in this setting? And for every scenario, it was more common for the endovascular physician to say, yeah, I would, than the medical physician. So we want to get to the point where these are basically the same line because we have really good data. So, I've talked a lot about what the shortcomings are. So where do we go from here for submassive PE to get to that better place? And the reasons, I think you could probably list them yourself at this point. But the reasons we haven't been able to determine whether CDT is effective for PE is we haven't randomized patients yet. If you look at the number of patients that have been randomized in systemic lytic trials, it's over 1,500. In fact, it's over 1,700, frankly. And only 59 have been randomized into CDT trials, and that was a non-US trial. And then, this idea that the RV to LV ratio at 24 to 48 hours is sufficient is really needs to go away. We need to figure out how CDT affects longer term outcomes, how it affects shorter term outcomes if we can, although those are much less frequent. So powering a study adequately to answer that question is going to be very difficult. But the guidelines are in support of us doing something big and bold. You look down the list from the American Heart Association, European Society of Cardiology, SIR, all of these other societies, they're all telling us to run this randomized controlled trial to help us out. And really, if we can dream a little bit, it would achieve much more than the primary objective of just trying to figure out whether we should do this or not. You look at the stroke trials, you look at the Attract trial, we got major insights into the biology of the post-thrombotic syndrome, when we should employ it, the limits and the efficacy of catheter-directed therapy. All of these results are spurring new research and device development, and it's also focusing where we should be putting our attention. Similar PE trial, we'd be able to clarify the natural history of PE. Even the natural history of PE in the year following PE is not really that well known. Figure out which novel risk factors could help us know which patients will actually benefit from intervention. And then the biological insights are really something that would drive research towards a better future for these patients. So when we design a trial like this, let's say we're at a chalkboard and we're trying to put together what the elements of such a trial would be, we're looking at these real things. These are real issues we have to consider when designing a trial. The incidence of PE, the amount of equipoise in what subset we're gonna select, and then the endpoints. What are we gonna choose as endpoints to actually make this trial happen? So taking this first point of incidence of PE, well, we talked about how massive PE is a very low incidence. Low risk PE has a very high incidence, so enrollment wouldn't be difficult into a low risk population. The problem is that this is really not a population you're going to go after for thrombus removal initially. But there's enough equipoise in the submassive group, and there's enough patients in the submassive group when you're talking a 25 to 40% incidence that you could potentially enroll patients with submassive PE into such a trial. As far as equipoise and endpoints, we'll start first with equipoise. There's clearly a lot of equipoise about submassive PE. We do not know whether we should be doing this routinely or not. And some people would argue that we should, and others would argue we shouldn't. And that argument needs to be resolved with a good trial. Now, finally, the endpoints. What is the right endpoint for a submassive PE trial? Well, mortality, as we saw in the PYTHO results, is very low. So if you're trying to show a difference in mortality, we saw in that Chatterjee meta-analysis that you'd probably need on the order of 1,800 patients. Now, just remember the Attract trial was 692 patients, and it was a Herculean effort by that steering committee to get it done. And they did get it done, but it was not easy. So you can imagine tripling that number. It's just not feasible in a single trial to do that. So I think we need to start putting away the idea of even clinical deterioration being a primary endpoint for an endovascular therapy trial. So then what are we left with? Actually, the long term. This is a table that talks about peak oxygen consumption. And basically, through cardiopulmonary exercise testing, you see that the incidence of reduced peak oxygen consumption is pretty high. In the ELOPE study, which I alluded to in, I think, the second or third slide, 46%, almost 50% had a reduced peak oxygen consumption. And then these other studies confirm that the number of patients that actually suffer from reduced peak oxygen consumption in the 6 months to a year after a PE is pretty high. And then functional capacity is also decreased functional capacity is also common after PE. We performed this meta-analysis and found that NYHA class greater than 2 happened in about 33% of patients. This means at least a mild functional limitation, and about 10% of patients have an NYHA class of 3 or 4. Now, it's hard to tease out if they had that before the PE as well. Certainly some methodological limitation with all of these, because you can never really gauge at the time of the PE what that person's functional status was. And you can't run a CPET at that time, and really doing a 6-minute walk test at the time is not very feasible. But if you also look at their 6-minute walk distance results, there's 415 meters, that's in the 4th percentile. So really for adults, it should be in the mid 500s if you're a normal person. But so basically what I'm trying to show with all of this is that this idea of a post-PE syndrome, a combination of reduced quality of life, reduced functional capacity, reduced exercise tolerance, is fairly common and happens in about 30 to 50% of patients. Why does this happen? Well, nobody truly knows, and it's not entirely clear why some people get it and others don't. But I guess the most, go-to hypothesis is that residual thrombus after submassive PE sticks around because anticoagulation doesn't get rid of it. And that's true in about 1/3 of patients at 6 months. So 33% of patients, if you did a CT scan or a VQ scan at 6 months, would have residual thrombus. And that residual thrombus is thought to increase pulmonary vascular resistance, increase dead space, contribute to continued RV dysfunction that may not even be revealed with a resting echocardiogram, but might be revealed when the patient is actually exercising. And it might have been an athlete who, is just not able to get to their peak level of exercise as they were before. Now, all of this is manifested in these clinical sort of situations where there's a 2-fold increase in mortality in these patients. VTE recurrence is increased. CTEF is increased with these patients that have residual thrombus. They have more functional limitation, short 6-minute walk distances. Their QOL is decreased. So all of these are associated with residual thrombus. And really the question is, if we arrest this right here, can we prevent these long-term consequences? We don't know the answer to that. Well, we're gonna try to do this. This is the PTRAC trial. This is the trial that we're trying to get off the ground. We did receive a U34 planning grant to try to spur this along, and I think it was very useful in getting us to a point where we have a very strong trial that we'll be presenting to the NIH. The due date for this resubmission is March 11th. And really, we're trying to answer this question once and for all, or at least get closer to answering this question by enrolling patients and following them and randomizing them and looking at their long-term and short-term outcomes, and outcomes that will actually matter and change clinical care. So after all of that, I could probably distill this talk into this slide, which is that for massive PE, we need a prospective registry to really understand which therapies and when. And for submassive PE, there's no question that the next step in our development as physicians, as scientists, as clinicians, is to conduct this randomized control trial in some way or the other. So that's what I have. I kept it relatively brief because I didn't want to bombard you with too much, but I think this will hopefully open up the floor for a bunch of questions and discussion, and I really look forward to it. So thank you very much for your attention, and let's talk about it.
Thank you, Dr. Sista, for the excellent talk, and I wish that we could have applause for you, live applause. But that was a wonderful review of where we are, and it's exciting that you're embarking on that trial. So good luck to you. And it's cool to hear about how you thought about how you're making it. If people could type questions in the chat box or unmute yourself, that'd be great. We have a comment from Dr. Halen on we really don't know how lower doses of lytics over longer periods of time mimicking ECOS protocols would work. So basically, does ECOS do anything versus longer term lytics? Or what's your thought on
So
that?
is the question low dose systemic lytics or?
Yeah. Well, so the question has two arms. Everybody quotes ECOS data, and they've shown efficacy driving doses down to 12.5 milligrams over 12 hours. Whereas anytime you suggest catheter or non-catheter directed lytics, everybody talks about this supposed full dose or half dose, 100 or 50, neither of which really exists. And so, the question I have asked for years is, what if we just use less lytic over longer periods of time through an IV administration in non-occlusive clot? So in patients where we believe that IV therapy would be of some use, instead of hitting them very hard, very fast, and risking these bleeding complications, why don't we just maintain a lower level but longer lytic state?
Yeah, so I think that it's actually we could talk about this particular issue for hours, I think. So a couple thoughts. The first is that we've never done a dose escalation study for systemic lytics. And there are some that really would like to do that. There were 3 studies in the 1990s that looked at reduced dose lytic administration. And there really was no difference between, a little less, anywhere from 50 milligrams or less compared to the full dose in terms of bleeding or efficacy. Then there was the whole Moppet trial that Sharifi put together. And it is very methodologically limited. And some of its results are a little not believable and hasn't really been reproduced. And there hasn't been a positive study for reduced dose TPA since. I think that what you're describing, Neil, is ripe for starting with a translational model, and going into if there's promise there, going into a phase 1 trial, where you just literally do a dose escalation to see if you get, at what point you actually make a difference. Sorry about that.
So I've been fascinated with this for some time and been kind of trying to push this. The issue comes down to scope and scale, right? So this is going to require quite a few patients, and one hospital is not going to be able to do this. So just something to throw out there.
Yeah. And just a thought about the Optimize trial. So again, without a control group, the idea that at 48 hours you've reduced the RV to LV ratio, that's your primary outcome, it just doesn't hold, because what you're really arguing is, well, maybe anticoagulation is really driving that RV to LV ratio. If you're giving 4 milligrams of TPA and you're getting the same RV to LV ratio at 48 hours as if you give 18 milligrams of TPA, maybe what you're really doing is just letting anticoagulation have time to, auto-lyse and and remodel the pulmonary circulation in such a way that the RV is no longer decoupled and is actually, doing okay. And so what was interesting in the Optimize trial is that the higher the dose of TPA, the more TPA given, the more thrombus clearance they got. So while they focused on RV to LV ratio, what was a sort of footnote in the paper was that there was a lot more thrombus clearance when you gave more TPA. And if ultimately more thrombus clearance leads to better long-term functional outcomes, that would argue for increasing the dose to the point that you're at least effective and there's a safety sort of ceiling associated with it. So yeah, lots of work to be done on dosing of TPA.
Thank you. Our next question is from Dr. Patel, who is one of our trainees at Brigham. At Brigham, we actually are not involved. IR is not involved in the PERT team. It's cardiology. And Hita Patel asks, any thoughts on how to get hands-on experience if IR doesn't control the PE space at a current training institution?
Yeah. This is a much bigger issue than PE. I really hope that at some point we as endovascular physicians can get over the turfs and just use use our expertise to train our trainees in everything. Ideally, you have a situation where you have everybody in a room, and we all realize how important it is for people to be trained, and rising tide raises all boats situation. Unfortunately, all politics are local. It's very possible that a vascular surgery resident is asking the same question at my institution. And it's unfortunate. I don't have any, I think one way to do it is approach your attendings and say, is there any possibility, approach the cardiologists and just start making connections and see if there's an opening over there. But it's not, I don't have a great answer for you, Dr. Patel, sorry.
Can I supplement that answer?
Please.
So I empathize with you, and I'll say, as your career goes on, your postgraduate career goes on, there's always going to be new things you'll be learning. You have to rely on your training, the fundamentals that you're learning, to apply to a lot of scenarios that are going to unspool themselves over time. And you should gain some confidence in the expertise you're gaining now in acquiring these skills. You're not going to work where you're at now forever. And when you get to new places, you might find opportunity. I know I found opportunity in this space when it comes to treating PEs, just by being present, knowledgeable, and eager. And I would just approach the director of the ICU, approach the ED doctor treating these patients, and I would approach my own diagnostic radiology colleagues, and I'd say, when you see somebody with a PE, think of me first. And that's how I kind of built those cases. And, as Dr. Sista said, every hospital has its own culture. And you might find when you go someplace else, there might be more accommodations made for you in this space. Was that okay to say?
I think those are very wise words.
Thank you, Herschel. And Hitab, I know I spent time with interventional cards now as a fellow, so I think we could set that up for you also. But it is interesting when different specialties are doing different things. I like what you said, that we're all endovascular specialists and there can be some common ground. Shams Iqbal is asking, what's the average time between when the PERT team is activated and when you do a case? So it's activated overnight, or you're doing the case immediately in the morning?
Usually it's based on the severity of the case. Obviously, massive PE, you're getting in as quickly as possible. If it's a submassive PE, it depends on certain parameters for us. So if you see somebody who's hovering in the 90s systolic, so technically submassive, if you see their lactate is elevated, it's like in the 3s. If you see their LFTs are going up, you look at their echo and it's just terrible, that would probably prompt us to go in more quickly. But most of our PERT activations for submassive PE, we give a trial of anticoagulants for about 24 hours. And then we either repeat the echo, or we take a look at their vitals, or we see how they do walking to the bathroom or walking in the hallway. And if things are improving, we will tend not to pull the trigger. But if they're not, and there's a lot of clot burden, the echo is still looking pretty crappy, we will pull the trigger at that point. But this is our clinical protocol. When it comes to enrolling patients in trials, this is where PERTs are really great. And if you have pulmonologists that are on board with moving the field forward and the endovascular field forward, they'll do a lot of the work for you. In fact, at our institution, the site PI for both the Extract PE trial and the Rescue PE study is Nancy Amoroso, and she's a pulmonologist. And so it's great to get them involved in an endovascular trial, because then they're really engaged in it. And, I think that when it comes to trials, we probably do the case within 8 to 10 hours of the activation if it comes overnight. But if it comes during the day, we'll get that patient in pretty quickly, if that answers the question.
Yeah, thank you. Great. Another question is from Dr. Halen is, can you discuss CDT in the world of COVID? I guess that's a big topic, but I'd be interested. I know that on the SIR message board, there was talk about, well, are these clots different in some way? But I mean, what has your experience been recently?
You know, I hear a lot of stuff from my NRA rep saying like massive PE, like back to back nights, and I do hear a lot of that going on. I've actually seen a lot more DVT work than PE work. A lot of big DVTs, IVC clot and iliac clot. We've done a lot of those cases recently. And a couple of them have been in COVID patients. And the COVID is not always acute. It can be a little bit later. I think you can still intervene on these patients, but I think our threshold has been higher. You know, so really, you know, the 6 submassive PEs, maybe the ones that, mostly because of an exposure issue. You know that submassive PE is going to most likely be okay. And so there's a real risk to everybody bringing that patient down. And especially if it's not totally clinically clear and indicated that should be, that you should do an endovascular procedure. I think our thresholds become higher, frankly, for PE patients. And then, of course, if it's a bad COVID case, you have the issue of, you know, microthrombosis in the pulmonary circulation plus parenchymal abnormalities, and trying to tease out which one of those is causing the hypoxia can become quite complicated. So I don't think nobody I know has figured this out. But if you guys have really kind of gotten to a place of comfort with it, I'd love to hear.
Yeah, it'd be great to hear if anyone has comments on that. Right now.
I can just say personally, we've just been less ready to come charging in for submassives in COVID positive patients. And our PERT team has been very responsive and accepting of that. And we've been doing, you know, peripheral, both anticoagulation and lytics. I don't know what the answer is. And that's, you know, the question. I haven't seen a true massive on a COVID patient, but we've seen quite a few submassives. And I think that's something that in retrospect, we're going to have to figure out what we know.
Great. Thank you, Dr. Halen. We have another question from one of our trainees at Brigham. Will Johnson is asking, maybe referring to the case that you showed, when in PE cases where the patient has an IVC filter, is it difficult to get the flow retriever past the filter if you're coming up past it?
I mean, it can be. It depends on how the wire gets through the filter. So I think very careful wire placement. So if you take an option filter, for example, and you put it through, you know, some of the small little windows at the top of the filter, you're not going to be able to get that sheath to go past it. So I think the most important thing is watch it very carefully as it passes the filter. And just make sure that it goes smoothly. The other thing is, you know, this is going to be relatively uncommon, but it can happen. And especially if you have a tilted filter that's really not filtering the cava, you might find a patient who's got the significant PE in spite of having a filter. But I think it is doable. You know, now they have a 24 French device for PE. Again, my personal practice in submassive PE is not to go after that with an NRA device. I think in massive PE, you have a lot more justification for taking up a very large device through the heart and risking, you know, cardiac damage and pulmonary damage. But you know, I think care along the entire length of the venous system is necessary, but it is doable.
Thank you.
In fact, we did a flow retriever case today for a large left common iliac clot, and the way this is not totally related to the question asked, but what we did was we placed a Gunther tulip filter and then I call it a filter on a stick. And so we just left it attached. With the Governor tulips, you press a button and it releases the filter. We just didn't press the button. And so we just left it in there. And then we took the flow retriever down, and we used the 24 French device because we found it to be very effective in the cava and the iliacs, and took it all the way down into the common femoral vein and pulled out the clot, and we were able to get it past the filter. Now the tulip itself doesn't have a lot of, it doesn't have a ton of metal, and so it's only got 4 limbs, and so that's part of the reason it's easy to get that flow retriever past it. I think a more bulky filter in terms of all its nooks and crannies may make it more difficult.
Great, thanks, Dr. Sista. I think we have one more question right now, and then we can move on, or 2 more questions, and we can move on to case presentations. Raja Shaikh is asking, would you chase a submassive PE if it occurs during DVT thrombectomy? So almost a follow on to what you just mentioned.
So you're doing a DVT thrombectomy and you send a clot up to the PA and the patient starts having problems. Well, I think it depends on how bad the problem is. So one important point is that in the 2000s, there's data that shows that if you did just pure mechanical thrombectomy, you increase the risk of symptomatic PE. So if you're doing just mechanical thrombectomy, and we don't have data that the new devices are any different than the old, you may want to cover yourself by placing a filter on a stick or placing a temporary filter that might be removed at the end of the procedure. If you're using pharmacomechanical techniques, so things like angiojet, we used to be the trellis, but whatever, then you might be able, if clot isn't hanging out in the IVC, at least in the ATTRACT trial, it was left up to the investigator, but the routine placement of IVC filters was not encouraged during CDT, PCDT in the ATTRACT trial. So, but if you're using only mechanical techniques and not using any fibrinolytic drug, you may want to consider placing a filter. That's point number 1. So then, look, if you send clot up to the lungs, you watch carefully. Hopefully this is a patient that is on anticoagulation. You really shouldn't be doing a whole lot of thrombectomy on patients that can't be anticoagulated. That is a bad idea because they're just going to rethrombose. So I always make a deal with whoever is referring the patient. Hey, if you can put this person on anticoagulation, I'm willing to give it a shot if it's clinically indicated. But if it's bad enough, yeah, you have to go after it.
Great, thank you for that. And everyone, these are such rich questions. This is excellent. Neve Vo is asking, Dr. Sista, you mentioned the NYU trial patients for 24 hours on systemic lysis before reassessing for endo options. Is the 24 hours based on a trial or an institutional consensus?
Just to clarify, not systemic lysis on anticoagulation. If I said systemic lysis, I misspoke. So it's institutional consensus. I think some people, it's one particular pulmonologist really likes this. I don't mind it so much because the data is so not in favor of going crazy on submassive PE right now, unless we prove that the long-term is improved with routinely doing this. So I don't have a problem with it. I do, and our group is so careful about monitoring these patients, which is what would happen in the Pytho trial too. If you think about why the Pytho trial was so different than the ICOPER. ICOPER was late 90s. People didn't really, were they promptly anticoagulating? Were they aware of the rate of clinical deterioration? If they didn't, were they watched carefully in the ICU as much as we watch our submassive PE patients now? So I think there is something to watching and waiting if you are watching carefully. So I don't have a problem with it.
Okay, great. Thank you for that. Again, excellent questions. We now are going to have some cases. Dr. Sista, so what we have 3 cases for today, and I'll ask you to award the best case presentation at the end after the presentation. So let's start with Kay Zhang from Brigham has a case to present. And we'll go in reverse alphabetical order of the 3 people presenting. So it'll be Kay, then Trevor Lewis, and then Curtis Hahn at BMC. So Kay, you can screen share. Okay, you're muted still.
Great, can you guys hear me? Is it my slide or is it a presenter view right now?
Your slide looks good and I can hear you.
Terrific, okay. Good evening, thank you very much for the opportunity to present a case. My name is Kay Zhang and I am an R1 resident in the integrated program at the Brigham. And the case I'll be presenting is very timely given our talk and the discussion we just had. I just want to thank Dr. Sista for that great talk. My talk is titled actually the use of the Inari retrieval device to retrieve an IVC filter-associated infrarenal thrombus. That's one of the first cases of using the Inari device at our institution. And I was lucky enough to be a participant in the case. So I have no financial disclosures and definitely no financial ties with Inari. And the history is our patient JB is a 42-year-old female with cervical adenocarcinoma who has underwent chemo and radiation back in 2018. Has had a number of surgeries. She's status quo a complete pelvic accentuation, as well as a low anterior resection with diverting loop ileostomy and cystectomy with a neobladder that was created towards the end of 2019. She was recently admitted this past December for bilateral acute pyelonephritis and acute vaginal bleeding. And at the time, she was found to have an infrarenal IVC clot with bilateral iliocaval burden. So she, due to the vaginal bleeding, was not anticoagulated and was given an IVC filter due to the clot burden. And more recently, over the course of the past month, the pyelonephritis evolved into bilateral hydronephrosis, and we placed bilateral PCNs over the last 2 weeks. And afterwards, she was transitioned over the last couple of weeks onto apixaban, and she was tolerating that well. So there was discussion of retrieving this filter, which at this point now has been in for about 8 weeks. So this is a CT that was done a couple of weeks back, demonstrating the bilateral hydro. This was prior to the PCM placement, but it shows the filter in place, and it's tilted approximately 40 degrees with the apex in the left renal vein. And it was thought it was due to this chronic IVC occlusion with the extensive clot formation in the infrarenal IVC, and has led to a significant amount of collateralization around that segment. And here's the 2 coronal still images showing the filter in the tilted angle and the extent of that clot. And at this point, the clot is almost 2 months old. So this was a IVC filter retrieval with an attempt to thrombolyse the infrarenal iliofemoral clot. This was done by my attending Marie Koch, and the fellow was Giulio Talentari. So we started by obtaining right groin access into the common femoral vein. And through this access, we performed a venogram, which demonstrated occlusion of the proximal common iliac near the bifurcation and the development of extensive collateralization. So we kept the O1A access sheath in place, and we accessed the left side. So after ultrasound guided access to the left side, the access itself was actually pretty challenging. And you can see from the run that the distal thrombus involved the majority of the left groin. So we advanced through the clot through the right side using a glide wire and Barrington catheter, and then gained right internal jugular access and passed down a 16 French sheath and put it right by the legs of the IVC filter. And using a hand run injection, we were able to show with pretty forceful injection that the clot burden was right below the IVC filter. And so using a gooseneck snare, we were able to pull an exchange length Amplatz wire from the right femoral access into the right IJ sheath for through and through access. And through the right femoral access, we placed a 13 French Inari clot retriever sheath. We actually started out with the 16 French, but had a little bit of trouble deploying it. It got stuck, so we actually had to remove it and place the 13 French, and yours truly held pressure to account for that 3 French difference. And through that access, we actually didn't end up saving our runs, but we passed the clot retriever device and basically parked it right into the sheath that we had in the right internal jugular access and unfurled it right under the IVC filter and pulled down as much of the clot as we could. We made multiple passes, making sure to turn the device at 90-degree intervals to try and get all parts of the IVC. So by doing this, we were able to remove numerous clots of various ages, with some containing fibrin plaques. And afterwards, we performed angioplasty using a 14 millimeter Atlas balloon from the bottom of the IVC, making sure to avoid the IVC filter legs, and down into the common femoral vein. So after the angioplasty, the venous ram demonstrated in a much more open IVC. However, there was still some clot, namely right under the IVC filter and within the IVC filter itself. So we switched to the, we would exchange the 13 French clot retriever sheath for a 16 French retriever aspiration catheter, and we parked that right into the IVC filter and performed multiple suction thrombectomies to remove any residual clot. And this was actually incredibly effective in getting a lot of the clot out, but of course, each time we did this, we lost 60 cc's of blood. So we made 3 passes of suction using this method. And afterwards, the venous ram demonstrated a patent IVC. And at this time, we were deciding whether or not we wanted to pursue trying to treat the clot on the left groin. And the decision was made to stop at this point because the primary indication for this was to remove the filter, and also the patient didn't have any symptoms in the left lower extremity. So we felt comfortable that we had restored flow through the main portion of the IVC, and that throughout the entire time we had the filter in place in case we did dislodge any clots. There was also thought that about retrieving the filter first and then using the clot retrieval device from the IJ access as a temporary filter in case we did dislodge things. But after we got the good flow, we used the gooseneck snare and just very quickly successfully retrieved the IVC filter. So the final venous ram, this is the final run we got, demonstrated a restored IVC flow. And we made recommendations after ending the case to the oncology team to start the patient on stronger anticoagulation, levodopa warfarin, for 4 to 6 weeks. And this is the final still images showing the pre-treatment and the post-treatment of the IVC. And this is when we collected all the clot that we removed and laid it out in the shape of the IVC along with the filter. This is all the solid clot, and that was compressed and removed during this procedure. Thank you for your opportunity.
Thank you, Kay. Great case. Good images for the case also, and a very thorough presentation of everything that you did. Any questions for Kay? Dr. Sista, I was going to ask you, when you're using larger devices, are you in the venous system, are you just holding pressure? Are you ever pre-closing or using any other closure methods, or is it really just pressure?
Yeah, I mean, we do a purse string at the end of a large access sheath case and just hold pressure. I don't like reversing anticoagulation with protamine or anything like that. We very aggressively anticoagulate these folk. I tolerate a little bit of a venous bleed for the sake of not having thrombosis on the table. I think this case is interesting because I agree with the decision not to try to do this in the acute phase when you can't anticoagulate the patient because of vaginal bleeding. You know, it's very frustrating to do a case like this and just have that patient rethrombose. It is bold certainly to do it 8 weeks later because the clot is going to be more chronic, and so being able to remove that clot percutaneously is going to be more difficult. Not that it can't be done, and I think that the clot retriever has the ability to get some of that subacute chronic clot as well. So I think this case was handled quite nicely.
Then we'll move on to Dr. Lewis from Beth Israel will present a case.
All right, let's see. All right, good evening, everybody. Dr. Sista, great talk. Good to finally hear you speak. I have a couple of quick cases, a couple of cool prostate cases that I wanted to show. Kind of highlight a couple of the things that we've been doing at the BI, and I kind of organized them by benign and malignant. So first, our benign case. So a 62-year-old guy with BPH and lower urinary tract symptoms, primarily incomplete emptying and frequency. His IPSS score is 16. Quality of life is 5, so unhappy. He was offered TURP, but did not want TURP, and so he found us. The imaging has a 95 cc prostate, and we offered him a PAE and consented for it. So in general, there's been a lot of talk on social media and lectures lately, but our PAE setup, if we can do a radial approach, we will. He's 67 inches, so he kind of meets like a 5'10", less than 5'10" cutoff. So we did a radial access. We use a 125 centimeter Berenstein microcatheter. We generally use the same one every time if we can. 2.4 French prograde and Fathom microwire. Base catheter, glide wire down to the internal iliacs. Oblique DSA, cone beam CT if we need to find the PA origin. Microcatheter and wire into the PA. And then we embolize with dilute 1 to 300s. So here's our left run on this gentleman. And just to kind of outline the anatomy for everybody, this is like kind of a typical anatomy, like what we get. We'll do ipsilateral 30 to 35 degrees, cranial about 10 degrees to kind of lay out the internal iliac, the anterior division really nicely. So on this, the left side, it was pretty straightforward, and our left prosthetic came off of the proximal IPA. We come back AP for our PAE, and here's our pre and our post. So when we came back to the right, I wouldn't be showing this case if there wasn't something interesting going on. When we get to the anatomy here, we see an obturator, an IPA, spherogluteal, but the right prostate is kind of a mess. What's going on? There's a tangle of vessels kind of where we think the origin is, and there's several candidates, but nothing really clear. So what should we do? Give up? A lot of people, this has been written about, and they achieve a high degree of success in terms of IPSS score improvement, just embolizing unilaterally. We could evaluate the atretic tangle of vessels and probably frustrate ourselves for hours. Or we can kind of evaluate to see if there's something else we could do and maybe get some more imaging. So with this case, we did a cone beam CT. So the 3D is really hard here to pick out, but there is this collateral that kind of fills off the distal IPA. Probably have to press the I believe button, but it does come off of there. It's just hard to see kind of this the best overlay I could find. When we advanced our microcatheter out into the distal IPA, you see the kind of like this retrograde filling and reconstitution of this of the distal branches of the prostatic artery. And just so you believe me, here's a kind of like a coronal reconstruction of the cone beam that was done from this position, where you're seeing filling of the kind of inferior aspect of the right prostate, right prostate gland. So a right prostate embolization was performed via retrograde approach from a distal right IPA branch. We kind of have it open in like an obliquity here to show the pre and the post. And so, you know, when we're looking at this, is this like very uncommon? Really kind of unclear, but the folks down at Miami who do a large volume of PAEs as well, they wrote a letter to JVIR and kind of talked about this. And so something that we were thinking about is, you know, in patients with atherosclerotic disease, the population might kind of predispose to this. I mean, these are older males. A lot of them have arterial disease. And so with a high volume of PAEs, this might be something that, I mean, while uncommon, it might not be as rare as maybe we might think. So clinical follow-up, his IPSS score dropped from 16 to 8 at 6-week follow-up, and his quality of life went down to 2 from 5. 6-month follow-up was scheduled, but he canceled. COVID was kind of going on at that time, and he said his symptoms were great and couldn't thank us enough. And so he said he'd call us if he needed more evaluation. So moving on to our malignant case here. 79-year-old gentleman with prostate cancer. He's had external beam radiation therapy, as well as androgen deprivation therapy. He had recurrence 2 years later, got brachytherapy. And now 3 years after that, he's having a recurrent lesion along the left prostate, seminal vesicle, and some oligometastatic disease to the right acetabulum. He has pretty bad comorbidities. His diabetes is pretty poorly controlled, kind of just due to like health maintenance issues. And so along with the multidisciplinary team and the patient, they kind of decided that they wanted to do a directed therapy rather than start ADT again, just because of kind of the side effects that has. So we offered and consented him for image-guided prostate cryoablation. So what we decided to do rather than the MR method is we decided to do CT and ultrasound guided. We wanted to adequately cover the lesion. And so we used multiple probes. A urethral warmer was used for this just because cryoablation, we were worried about potential development of a urethral stricture. And we placed a Foley at the end of the case and had him follow up in clinic 1 week later for a voiding trial. Use intermittent CT and ultrasound to evaluate the ice ball during the case. Here's the Axeman scan that shows this lesion along the left prostate area where the left prostate kind of was in seminal vesicle. Patient was prone, inserted the probes into this lesion, did 2 superiorly and 1 inferiorly, and used the 1.7 millimeter probes. Did a little bit of hydrodissection around between the lesion and where the urethral insertion, or the urethral insertion, sorry, and did 6 cc's of hydrodissection. Here's the ice ball at 8 minutes, and we did 2 cycles to get complete coverage. So I know that CT-guided cryoablation for locally recurrent prostate cancer is something that isn't widely done, but this is a small study that was done out of France in 2013. And this was, I think, the first case that we had done in a while, a couple of years ago, but happy to say that we've started doing a handful of them lately and have had good results so far. So this patient came 1 week later for voiding trial, and and fully removal, and went without any kind of event or problems. The patient followed up, has been clinically being followed up by hem-onc and urology, and no imaging findings of recurrence or increase in metastatic disease. His PSA natered 2 months following cryoablation, and we've actually been able to kind of hold him off of ADT for greater than 2 years, which is kind of what his biggest goal was, given his advanced disease. Questions?
Thanks, Trevor. It's cool seeing CT guidance for prostate ablation. I haven't seen it before. Any questions for Trevor? All right. Well, thank you for presenting. We'll move on to our final case, which is Curtis. Oh, Dr. Sista, please.
Yeah, Trevor, you didn't use the flow triever or clot triever for that case?
You know, advanced techniques
Do
are
better
something.
next time, okay? Do better.
Advanced techniques are, you know, things that we try to do, but, you know, yeah. Maybe the T14, you know.
Let's move on to Curtis, Dr. Hahn from BMC.
Hey, can you guys hear me?
Curtis.
Hey, Dr. Birch. So I see a lot of familiar names here. Really great to see everybody, especially during this cold week of winter. Thank you, Dr. Sista, for an excellent talk. Definitely a very, laid out a very comprehensive landscape for this case, but also my understanding of percutaneous management of PE, which I have relatively little experience in. So let me see if I can try to pull this case up. Oh, gave it away. Let's see here.
Like Curtis, start screen sharing too. We aren't seeing your screen yet.
Yep. Let's see. So let's do that. How's that look?
That's good.
Okay. So again, very opportune talk, given that this case was my last case on the rotation, which we did about 2 weeks ago. So I'm going to present a case of a submassive PE that was managed with aspiration thromboembolectomy. My name is Curtis Hahn-Scheidler. I am an R2 at Boston Medical Center, and this case was done with Dr. Bader. So the case was an 84-year-old male with AFib, A-flutter, not on anticoagulation, who was transferred from an outside hospital for PE. He was in a usual state of health until 1 week ago when he started developing multiple episodes of exertional dyspnea, particularly when traveling up the stairs. And then he acutely worsened with shortness of breath and fatigue the day before presentation. Of note, he was a former elite rower. And when he presented to the outside hospital, he was noted to be satting 84% on room air. His vitals were stable. He was normotensive. He did have an elevated D-dimer. And so they obtained a CTPA, which demonstrated bilateral right greater than left pulmonary embolism. A little bit of other past medical history and surgical history. Does have a history of hyperlipidemia, thoracic aortic aneurysm, moderate mitral regurgitation, and bladder cancer. Status post surgery and TURP in 2017. His family history was non-contributory. He was a former smoker, rare alcohol use. He's not on any home medications, and he was COVID negative. So he was transferred to BMC due to a lack of ICU beds at the outside hospital. And on arrival, again, he was afebrile. His vitals were relatively stable. They were able to correct his saturation to the low 90s on 5 liters of nasal cannula. On physical exam, he was not in any acute distress. His heart was irregular rhythm. His lungs were cleared to auscultation bilaterally, and he had no lower extremity edema. Labs were relatively unremarkable, although I will note that his BNP was 327. He was started on a heparin drip at the outside hospital and was continued here. And then they obtained a few other imaging studies. So they got a bedside echo, which demonstrated RV strain. And they also had a bilateral lower extremity ultrasound, which demonstrated DVT in the right mid-femoral vein, as well as the left mid to distal femoral veins. The CTPA from the outside hospital was uploaded to our system, and here it is. So I'll play this for you. Okay, so I'll play this one more time and kind of walk through. So almost immediately you see this kind of patchy airspace opacity up in the left upper lobe, which was thought to be potentially infarction. As we come down distally, we start to see clot burden here in the left main, but really it becomes very prominent in the right, involving the truncus anterior and also the interlobar arteries. As we come down a little bit further, we start to see that there's dilation of the right ventricle, there's flattening of the interventricular septum, and then finally, this clip doesn't do a great job, but there is indeed reflux of contraction to the IVC as well as the hepatic veins. Okay, so here are just single shots which really demonstrate the clot burden in the right main pulmonary artery, which correspond to regions of perfusion defect in the right upper lobe as well as the right middle lobe. Here is an axial through the heart where we can see this increased RV to LV ratio, as well as the flattening of the septum. So, you know, the talk that Dr. Sista gave was really enlightening, because when this case first came in, I was kind of questioning myself, like, what are we going to do to manage this? You know, do we do catheter-directed thrombolysis, or do we try something new? And that day that the patient had come in, the vice rep from Penumbra actually gave us a quick intro to the Lightning Cat 12 system. So that's actually what we did in this case, which was really cool. It was my first aspiration thromboembolectomy, and the first with the Lightning 12. So we got right IJ access with standard technique. And we got a 5 French pigtail catheter, which we used to select the right main pulmonary artery. And we can see here, you know, lots of filling defect here with relatively almost no perfusion of the right upper lobe, and certainly decreased perfusion in the right middle lobe. You know, again, referring back to Dr. Sista's talk, we kind of see this obtuse angle here, which is corresponding to our pulmonary embolism. So, you know, with the Lightning Cat 12, it operates over a 12 French system. So we upsized to a 12 French by 45 centimeter Ansel sheath. And we can see here that we're operating coaxially. This is the sheath, and then here is the catheter. We did this. It's quite maneuverable. You know, the goal is to kind of, you know, direct the catheter into the intended vessel, and then you want to rotate the catheter as well. And so we were able to do that without any wire. Just a short clip here kind of demonstrating that. I will say that with this system, you know, it's a smart system. It has a dual pressure sensor, so it's supposed to aspirate continuously when the sensor detects that it's in clot, and then it's supposed to aspirate intermittently when it's in patent flow. But what did happen was that every so often the catheter would clot off, and so here we see this kind of almost pipe cleaner device. It's called a separator, and this is kind of how we use the catheter with the separator in tandem. Okay. So then, you know, following treatment, I apologize, this is a near completion run. Our final run wasn't of greatest quality, but this really demonstrates kind of the fruits of our labor here. So here we see very nicely restoration of flow in the right upper lobe, as well as the right middle lobe. There's still a little bit of filling defect in the lower branches. So we, you know, did go after that after this run. And then this was our final shot, which unfortunately did have some motion. So the result, you know, this was our clot burden. You can see a lot of clot here. But the great thing about this device, it was a new device, was that our EDL was 175 cc's approximately, which, you know, in my N of 1, I understand that to be relatively low. So it was a very successful procedure. And then probably more exciting and kind of just really phenomenal to see with the patient on the table. I mentioned that we were able to correct the oxygen saturation to like low 90s, 94% on 5 liters. But after 3 to 4 passes with this device, we were actually able to get his O2 sats to 99 on 2 liters. So just very, very promising. With the rest of his hospital course, he was weaned to room air shortly after the procedure. He was transferred from the MICU to the floors. And then he was discharged home post-procedure day 2 on apixaban. So that's the case. I'd like to open it up to the floor for questions, and I'd like to actually pose a couple of questions that kind of go together. And that is, I was wondering what other providers have, if anybody else has had experience using the Cat12 system, and what else do you particularly use, and how would you compare the different devices personally?
So I've used the Cat12, great case. I've used the Cat12 in the Cava and the iliac. I haven't had the opportunity to use it in the pulmonary circulation. Extract PE was with the Cat8 device. So, Cat12 was not part of the trial. I'm very curious how the Cat12 would, I liked how maneuverable the Cat12 device was. And it's always a lot more comforting to put a smaller bore device into the PA and not worry as much about Chord A and occluding the main PA with a large device. There's certain, theoretical benefits I can see with it, but I haven't personally used the Cat12 in PE yet.
Curtis, thank you for your case. That was a great case. Beautiful images, and it's cool that you got to see the patient improve quickly. Any other questions for Curtis? All right, I think that wraps up our case presentation. So 3 excellent cases with some variety. Dr. Sista, could you please tell us your judgment, the best case award
it's a tough one. It's a tough one. Excellent presentations all around. Well thought out cases. I think Dr. Zahn presented a great case, and going after chronic clot, I think that was the right thing to do for that patient. It's no fun to have a totally thrombosed cava. At some point that's going to come back and be a problem in a lot of patients. So very clinically necessary. I thought Trevor presented some really cool PAE cases way out of my fund of knowledge, so that's probably to his disadvantage. But that being said, for people that treat male genitourinary issues, these are novel and important cases. And of course, Curtis presents a PE case, which is just, near and dear to my heart. It's really an apples and oranges thing, but given the theme of the day, I'm going to go with Dr. Hahn, Curtis Hahn, for the PE case.
Congratulations, Curtis. You get an engraved pen. And we'll just play you a round of applause. Okay. The next thing we're going to do is just talk about our next meeting. It'll be March 8th. And that will be Maureen Cohey, who's now the chair of radiology at UNC, is going to talk about complications. So I want to finish this with another thanks for Dr. Sista. I think this was an incredible talk for everyone. You've heard it by all our presenters, but it's greatly appreciated. And I learned a lot, and I think we all did. So thanks again for joining us tonight.
Thanks very much. Thanks
Everyone. It was great.
All right. Good night.